Very good evening, everyone. This is Dr. Chaitanya Mittal, and today we shall be discussing infarct artery localization in ECG and its clinical relevance. So, first of all, this is the typical coronary angiograph findings that you get from our cath lab, and the same has been shown to you. So, as you can appreciate here, there is stenosis in the proximal LAD, and there is occlusion in the distal RCA. So the question that arises is for an interventional cardiologist, which of these arteries is to be stented first and which of these arteries does require stenting? So we cannot answer these questions without having an ECG that goes on to show that the angiogram only represents the anatomy. It does not represent the event, it does not represent the acuity of the event. So angiogram represents anatomy, not acuity. So the acuity of the event or how acute the event is, which is the artery, where does it localize, that information is only provided to us by the ECG. So if you look in this ECG, it is actually ST elevations in the precordial leads, V2, V3, V4. And as we have discussed so this presentation is at the postgraduate level or at the level of interns or maybe at the beginning level of a cardiology course. So we understand that you have read that precordial leads lead to an anterior wall MI, and you might have some idea that it actually relates to the left anterior descending artery. And indeed, in this case, this is the one that was stented. There are other additional details that you get to find out from this angiogram, but that is not the scope of this video because here, as you can see, this distal RC is 100% occluded. There is chronic thrombotic occlusion. There are grade 3 heterocollaterals. So you get collaterals and the collaterals are good. So there is good collateralization of this chronic occlusion and the cap is tapered. The other option is a blunt cap. So there are some differences in revascularization when there is a tapered cap or a blunt cap and when there is a presence or absence of collaterals. However, we should not go into that. The main point being because the acuity of this myocardial infarction corresponds with the territory of the left anterior descending, even though both have stenosis. The one that undergoes primary percutaneous intervention is the left anterior descending. Hence, there is immense clinical relevance of what we are going to discuss. So, how does it help? One, you get a confirmation of the infarct-related artery. There are new trials which give emerging evidence for complete revascularization, and we will discuss what the guidelines say towards the end. Other possibilities, assume you get 5 patients to the cath lab and all of them have a presentation of an acute myocardial infarction. So looking at the ECG, if you're able to localize the area of the infarct artery, you'll be able to estimate the myocardium that is at risk. And the patient which has the most myocardium at the risk should be the one which you should be taking up first for cutaneous intervention because time is heart. So in that case, you'll be able to decide. Last scenario, which is very important because often what happens is these patients come to the emergency department of hospitals and they are attended to by interns or postgraduates instead of a cardiologist. So it is very important that when these patients tell you that we have chest pain, you always look at the 12-lead ECG and rule out whether there is right ventricular wall involvement. We'll speak about how that is done because patients who have RV involvement, essentially RV infarctions are a preload dependent state. So nitrates are often given. We often give off sorbitates for chest pain. But in patients who have inferior wall MI with right ventricular extension, giving nitrates is counterproductive because it's a preload dependent condition. Nitrates will increase the preload and they will worsen the patient's condition. Patient might faint, go into syncope, and you might often confuse it with something else. So it is very important, and this is especially at the level of interns and the postgraduates, that if there is right ventricular wall involvement on your ECG, if there is RB extension, you should not be giving nitrates. So these are the relevant points that we shall be covering in our session. So first, let's talk a bit about coronary anatomy. So as far as coronary anatomy is concerned, this is a classical diagram and you will often see some people from their cath labs, they will represent the findings in this particular format. So as you can see here, this visualized to you is the aorta. And what you are able to see here is the right coronary cusp and the left coronary cusp. Okay, the non-coronary cusp is not shown. So these two cusps give rise to the coronary arteries. So this right coronary cusp here is giving rise to the right coronary artery. So the first branch that it gives off is the sinus nodal branch. So remember, around 60% of the times, some people say even up to 70% of the times, the sinus node is supplied by the right coronary artery. That's why bradycardia is common with RCA infarctions. Second is this conus branch. This is the conus branch. That is the second branch that is given off by the proximal part of the right coronary artery. So our understanding here of proximal, mid and distal of the right coronary artery, it is relevant in context to the branches it gives. Okay, so the right ventricular branch, so the RCA is actually the one, the right coronary artery supplies the right ventricular through the acute marginal branch. So these are mainly the right ventricular branches supplying the right ventricle. So the anatomical understanding is a proximal, mid, and a distal. Whereas from a practical standpoint, we only look at whether the occlusion is proximal or distal to the right ventricular branches. So if the occlusion is proximal to the right ventricular branches, you know that if you have an occlusion somewhere here, the right ventricular supply will be impaired. And those are the cases where you do not give nitrate. Whereas a distal RC occlusion means that these branches have already given off supply to the right ventricle. So that means the right ventricular wall is spared and it is not infarcted. So RV function is unlikely to develop in those cases. So in those cases, the occlusion is considered distal. So those things can be represented on this diagram, and further it finally bifurcates into the PDA, that is the posterior descending artery, and the posterior lateral ventricular branch. So the posterior descending artery, in as you all know, in 90% of the cases, 80 to 90% of the cases arises from the right coronary artery, and that decides the dominance of the circulation of the heart. So most of the times it is a right dominant circulation. In lesser cases, it's either left dominant coming from the LCX or co-dominant. That means it arises from both. Then you talk about the main left coronary and the first you talk about the main left coronary artery. So the LMCA, we shall be referring it to as the left main coronary artery. The left main coronary artery is the one which divides into two, LAD and the LCX. Okay. The LCX curves around and supplies the lateral part of the left ventricle, whereas the LAD comes on the anterior interventricular groove. So we shall be going into detail about how they are divided, but broad understanding is the LED is divided into a proximal, mid and distal, whereas the LCX is divided into a proximal, that is proximal to the obtuse marginal branch. So the LCX gives off an obtuse marginal branch which supplies the lateral wall. So you can have an occlusion that is proximal to the obtuse marginal or an occlusion that is in the obtuse marginal. Those are the possibilities for the left circumflex. Whereas the clinical relevant possibilities for the left anterior descending are many. You can have a proximal occlusion, a mid occlusion, a distal occlusion. The definition of distal and proximal is with regards to the septal branches and the diagonal branches. We shall be discussing this more in detail when we talk about the LAD in individuality. Predominantly, the septal branches, the first septal and the first diagonal, are the anatomical landmarks of distributing it into the proximal, mid, and the distal. Apart from that, you can have isolated septal and isolated diagonal occlusions. So let's go back here and look at this coronary angiogram findings, where you can see similar manner of presentation is here. So you have a proximal LAD, you have a proximal LCX and a distal RCA. So slowly, I hope these terms will become clearer to you. So this is a image, a representation of how some cath labs will report their findings of the coronary anatomy. So as you can see here, they have, so it becomes easier to interpret. If you're familiar with this anatomy, it becomes easier to interpret these findings. So this represents a proximal RCA occlusion here, correct? Similarly, you can interpret all the occlusions that have been quantified in this coronary angiogram visualization. Now there is a certain other standard anatomy, certain other standard nomenclature to be aware of. So when you look at imaging modalities, there are predominantly two imaging modalities that you will be dealing with. This is perhaps just a primer at the postgraduate level and is perhaps more relevant at the DM cardiology level. So for a primer, if you talk about it, you will be looking at two kinds of imaging. One will be a coronary angiograph or a coronary angiography view, Other thing, a new modality that is up and coming and very useful for a non-invasive evaluation of coronary artery disease, especially in patients who have CAD, is called the CT-CAG. The Using CT, you basically reconstruct the coronary anatomy of the heart. So there are both of these anatomies we are going to discuss in brief. So how do the coronary artery segments appear in a coronary angiography and how do they appear in a CT-CAG? So when you talk about an angiography, you have the right coronary artery, the LMC and the LAD and the LCX, correct? So the right coronary artery, as we talked about, gives the sinus node branch, gives the conus branch. Then the proximal part, that is proximal to the AMB, that is the acute marginal artery, which supplies the right ventricle. So you have areas that are proximal to it and parts which are distal to it. And this is how they will appear on a coronary angiogram. We'll have a discussion of the real images also, but a schematic would be like this. Then if you look at the LMCA, as we talked about, you will have towards the medial side or towards the inside, you will have visualization of the septal branches. Outwards, you will have the distal branches. This is the D1, the D2, and so on. So here you will have these branches, and note here the ramus intermedius is shown, and we shall be discussing more about the ramus intermedius when we look at one of the coronary angiograms. The last one is the left circumflex artery, and here, as you can see, there are multiple obtuse marginal arteries. And with respect to the first obtuse marginal, we talk about proximal or distal occlusions. Proximal being proximal to the OM1, and distal occlusions can be in one of the obtuse marginal arteries. Finally, if you look at the CT-CAG view, in the CT-CAG, you can visualize all of this. So you can imagine it is an axial section. Okay. So if you're looking at a person, you're taking an axial section. So you're going to cut the heart at one level. So some part of the heart will be anterior and some part of the heart will be posterior. And as you all know, the right ventricle is the somewhat the anterior part. So if you look at it broadly, this is the anterior aspect, this is the posterior aspect, and this is somewhat how your heart appears in cross section. This is somewhere the aorta. And as you can visualize here now, you can bring this visualization here and you're going to be looking at the cusps of the aorta. So as you all know, anteriorly you have the right coronary cusp. Anteriorly you have the right coronary cusp. Towards the left posteriorly you have the left coronary cusp. And towards the right posteriorly you have the non-coronary cusp, which does not give rise to any artery. So the coronary cusps are divided like this. The anteriorly you have the right coronary cusp. Posteriorly towards the left you have the left coronary cusp. So these, if you imagine on the CT-CAG, you'll be able to visualize the arteries. So just imagine this being transposed here. So if you look at it that way, you'll be able to visualize that and follow me that this is the right coronary artery, giving first the sinus nodal and the conus branches. And then here somewhere it is going to give off the acute marginal branch. So this will be proximal occlusions. And then finally it is bifurcating into the RPLB and the right posterior descending artery. The left coronary artery, so you can first imagine here, this is the left main coronary artery, which is bifurcating into two. The left circumflex artery, which is visualized here, and the left anterior descending, which goes here. You can visualize proximal, mid, and distal parts, and this is the left circumflex giving obtuse marginal branches to the lateral wall. So we shall have a look at these things in a angiographic view first. So just to give you an idea or an orientation about how angiographic views are oriented. So angiographic views can be provided in many forms. So you have multiple views and a lot of these have names. For example, you have a spider's view. But the standard nomenclature of these views, there are mainly two things to look at. Whether it is a left anterior oblique view or a right anterior oblique view. Second thing is whether it is a cranial view or a caudal view. Correct? So when you look at the first image, it is a left anterior oblique view, which basically means ignore the anterior posterior part. The left anterior oblique means that you are sitting here on the left shoulder of a person during the angio study. Second thing, it tells you that it is cranial. So you are on the left shoulder and you are above the heart. That is, you are cranial to the heart. So you are looking at the heart sitting here. So what comes into view is the anterior part, that will be the right coronary artery. Whereas in the RAO caudal, that is the right anterior oblique. So imagine you are sitting on the right shoulder and then caudal, which means if the heart is here, you come caudal to the heart and you're looking from below up. So you're looking from below up at the heart. So that is what you visualize. So that is the visualization that is needed and it will be very helpful even going forward. So the left anterior oblique view in the cranial part, this is the right coronary artery that is visualized. And as you can see here, the small conus branch going from it, then this is the right coronary artery and here it gives off a branch. This small branch is going to supply the right ventricle, also called as the acute marginal branch, which supplies the right ventricle. Finally, it bifurcates into the posterior lateral ventricular branch and the posterior descending artery. So these are the two branches that you end up with for the right coronary artery. Now looking at the right anterior oblique caudal view, so imagine you're looking at the heart from below. This is the angle of vision and this is what you are going to visualize. So you again are able to make out the left main coronary artery, the left circumflex artery and the left anterior descending artery going here. So there are certain views in which you are going to see the LCX on this side and the LAD on this side. Whereas depending on how you are viewing at the heart, whether it is a RAO caudal view or a LAO caudal view, you will be able to visualize separately. So because you're looking at it from the right side, the lateral supply, that is the left circumflex artery, is seen more in the center. But that center and mid is not the critical thing. So the left circumflex artery here and the left anterior descending here. So one more thing you can appreciate in this is the left circumflex artery gives off the obtuse marginal branches. So here you can see off the obtuse marginal branches arising from the left circumflex. Whereas the left anterior descending artery gives off the diagonal branch which supplies the lateral ventricular wall and the septal branches which go inward. These are going inward to supply the anterior two-thirds of the interventricular septum, whereas the posterior part, posterior one-third is being supplied by the right coronary artery. The septal branch is coming from the right coronary artery. So that brings us to an end of the angiographic views. Now we move on to see a short video on how these angiographic views appear, and you can refer to the YouTube links also for these specific ones. So let's have a look at the coronary angiography. So as you can see here, this is the left main dividing into the left anterior descending and left circumflex, the left circumflex giving off obtuse marginals. Now, in this another view, let's look at the left anterior descending artery. You can see inwards, it is giving some branches which are going inwards. Those are the septal branches. And the branches that are supplying superficially on the wall, those are the diagonal branches. Now this here is a LAO cranial view where you are able to see the right coronary artery giving off the acute marginal and finally bifurcating into the posterior left ventricular branch and the posterior right descending artery, the RDA, the posterior descending artery, the PDA. Now let's have a look at the CT-CAG, although it is not very relevant at the postgraduate level, perhaps more so at the DM cardiology level. You can see the cuts and just follow with me. This here is the ascending aorta. So somewhat anteriorly you will find the right coronary cusps and somewhat here you will find from the left coronary cusp you got the left main coronary artery giving rise to the LCX. The anterior cusp, the right coronary cusp has given rise to the right coronary artery. That will go forward and supply the right ventricle giving off the acute marginal branch. Whereas here what will come into view will be the left anterior descending artery. So this is the acute marginal branch which will supply the right ventricle. It will give branches to the right ventricle. Then further, as this goes further, you can probably see that this is the RCA continuing. That is your descending aorta, azygous vein, the RCA coming backward to supply the inferior wall and the esophagus. So that is about the CT coronary angiogram. So that was just a brief understanding before we go forward. Coming to the concept of, so we are going to go into ECG localization. So we should understand why we see changes on the ECG as we see them during a acute myocardial infarction. So first concept that is very important to establish is the one of why ST elevations in MI. It's not a straightforward answer. You cannot answer it with guesswork. It's not potassium efflux. The correct answer to that is actually a subject of debate. The most accepted theory currently is a doublet injury current. So there is a doublet injury current whenever there is an area of myocardial infarction, and it relates to how the myocardium has charge distribution across its cell membranes. So let's not go into the details in the physiological details of why ST elevation in myocardial infarction, but the injured area of the myocardium produces some injury current which leads to the formation of an electrical injury vector, which causes direct changes and reciprocal changes on the electrocardiogram. So an electrocardiogram is basically a surface representation of the electrical activity of the heart, correct? So let's assume in this case you have a occlusion of the left anterior descending artery. Now you should be able to understand that this is the injured region of the myocardium. This is called the area at risk. This area at risk now leads to an injury current, and that injury current is towards the wall of injury. So because this is towards the left, and this because this is towards the left, so now you look at the frontal projection and the horizontal projection. So in textbooks this will often be mentioned as FP and HP, the frontal projection and the horizontal projection. So if you would just imagine the ECG, if you imagine the ECG leads, the limb leads, that is the 1, 2, 3, AVF, AVR, AVL, they all lie in the frontal plane. Whereas the V1, V2, V3, V4, they are oriented in a transverse manner, that is in a horizontal plane. So if you look at the projection of the injury vector in the frontal plane, in the case of left anterior descending artery proximal occlusion, it goes upwards and towards the left. So where do you get the direction of injury vector? That is the place where you will get ST elevation. So the ST injury vector is in this direction. So you will get elevations in leads 1, leads AVL. So these are the places where you will get an ST injury direct change. And if you look at the negative tail of this vector, this is where you will start to get reciprocal change. So ST depressions in lead 3, 2, AVF, AVR is what you might get in such cases. Okay. Now, when you look at the horizontal projection, if this part is involved, so occlusion is towards the left side. So this is the right side and this is the left side. So you will get ST elevations in the left precordial lead. So more ST elevations in V3 and V4 as compared to V1 and V2. Okay. So that is the understanding of why you get injury vectors, why do you get injury currents. Moving on. Now coming to the core aspect of our discussion, this was some introduction. Now we will look at the various ECG patterns and we will go from the artery to the ECG. Towards the end, we will synthesize going from the ECG to the artery. So while going from the artery to the ECG, the first set of occlusions to be understood is the occlusions which affect the anteroseptal zones of the myocardium. And those occlusions we will localize to the left anterior descending artery. So when we want to localize to the LAD, we should understand the anatomy of the LAD. So looking at the anatomy of the LAD, this is the LAD as we have discussed, rising from the left coronary cusp. The left main coronary artery was dividing into the LAD and the left circumflex artery. That is proximal to what we have discussed. Now the LAD, as we talked about, it is divided into the proximal, the mid and the distal. So the anatomical landmarks which are very important is, so the LAD supplies what? The LAD gives supply to the lateral ventricular wall and it gives supply to the interventricular septum. As you might remember, anterior two-thirds of the interventricular septum is supplied by the LAD, while the posterior one-third is often supplied by the right coronary artery. So inwards, when it goes, it gives off branches to the septum. Those are called as septal branches, labeled as S1, S2, and so on. The supply to the ventricular wall is in the form of diagonals, so that is called as D1, D2, and so on. So usually the septal branch arises before the diagonal branches at a higher level. So the S1 is the landmark for calling it a proximal occlusion. So if the occlusion is proximal to the first septal branch, it is called a proximal occlusion. Then the other landmark for distal is the D1, the first diagonal branch. So if the occlusion is distal to both S1 and D1, it is called a distal occlusion. And as you can imagine, it is possible that the occlusion is distal to S1 but proximal to D1. In that case, it is called a mid-LAD occlusion. So these are the possibilities for a LAD occlusion. Apart from that, there can be isolated occlusions of the septal branches, isolated occlusions of the diagonal branches. There is one more variant of the anatomy in which the diagonal branch arises before the septal branch. So in this case, what happens is the occlusion, you can see here that the D1 here is arising before the S1. Rest everything else remains the same. The only concept is that this such an occlusion here between this will become distal to D1 but proximal to S1. So that is a septal occlusion which is not affecting the diagonal branches. So we will discuss these 6 variants of occlusions in detail and what are the ECG findings in each of these. So proximal and mid LAD with regards to the S1 and D1. You may please note sometimes anatomically the S1 and D1 are very short and narrow and they're not visualized on the CAG. In those cases, sometimes S2 or D2 become the landmark for proximal or mid occlusions. Okay, so far so clear. Now, when you look at occlusions of the LAD, you can either have a proximal occlusion or a distal occlusion, and there is a key difference between both of these. So, when you look at the proximal occlusions, they are affecting what? They are affecting the high part of the lateral wall. So, this is the lateral ventricle. This is the lateral ventricle. And imagine that when there is a proximal occlusion, more part of the left ventricle is involved, which involves the high part of the free wall. This part of the free wall is involved. As a result, as a result, because this right side area is relatively less involved and the bulk of myocardium towards the left is involved and more proximal myocardium is involved, the injury vector is one directed upwards. Second, it is directed towards clearly towards the left and towards the upward side. As a result, what happens is the positive current for this is seen in the form of ST elevations in V1 to V4. Whereas the negative tail faces the inferior leads, that is the 2-3 AVF, where you get ST depressions. Similarly, if you look at a distal occlusion, in the distal occlusion, these upper parts of the ventricular wall are spared. As a result, the bulk of the injured myocardium is located inferiorly. Okay, more inferior myocardium is injured, the superior myocardium is spared. As a result, what happens is the injury vector is now directed downwards. So because it is facing the precordial leads towards the left side, there is definitely ST elevation in V1, V4. That is common to both. But in case of a distal occlusion, even leads 2-3 AVF will go on to show you ST elevations. The point to pick up from this is if you are looking at an ECG and if you look at multiple leads having ST elevations, it does not always mean that it is a bad sign. Do not go ahead and simply close your eyes and label them as anterior wall MI plus inferior wall MI just because there are ST elevations in both V1 to V4 and 2-3 AVF. The lesson to catch is a more proximal occlusion, that is a more dangerous occlusion, may only have precordial leads ST elevation and in fact it may show more depressions in 2-3 AVF with more prominent reciprocal changes. Whereas a distal occlusion, which is technically less dangerous because less myocardium is at risk, will have more number of ST elevations on the 12 lead ECG. So let's say you have 7 leads showing ST elevations on a 12 lead ECG and you have only 4 leads showing ST elevations. Which one is worse? That is difficult to say because in a proximal occlusion, it is actually worse. You may only have 4 leads showing ST elevations with 2-3 AVF showing prominent ST depressions. That is the takeaway message regarding this. Now we shall go individually into each of these. We'll look at the injury vectors and we shall look at the corresponding ECG changes. So if you look at the proximal LAD occlusion, and obviously it implies that the occlusion is proximal to the S1 and the D1. It is proximal to both of these branches. So both septals and diagonals are involved apart from the main. Okay, not the main, the proximal part of the LAD, that is proximal to the first septal branch, that is involved. So as a result of which, where is the injury vector? And as you can see in our injury vector diagrams, this is the frontal plane. This is the projection in the frontal plane. Apart from that, here you can visualize inferiorly is the projection in the horizontal plane. This is the horizontal plane that is shown to you. We shall be discussing how the injury vector is oriented, and based on that we will come to a conclusion. Okay. So if you imagine this to be the left ventricle, as we discussed, the injured myocardium here is somewhat in this fashion. As a result, what happens is the injury vector is directed upwards. The injury vector is directed upwards, and because the septal branches are occluded, because it is proximal to S1, septal supply is affected. Remember the septal depolarization, the septum lies towards the right ventricle. So whenever you are looking at ECG changes, and you should always imagine the right ventricle doesn't exist. Imagine everything, because the bulk of the myocardium is in the left ventricle. So as far as electrical activity is concerned, it's only a cone of the left ventricle that is being visualized at. So if you imagine this to be the right ventricle and this to be the left ventricle, you can ignore the right ventricle. This is the septum and this is the free wall. So if the septum is involved, that means right side of the left ventricle is involved. If the right side is involved, the direction of the injury vector will be more towards the right side as compared to had the septal wall been spared. So now just have a look at the projections. So this was a superimposition of the injured myocardium. So if you look at the projection, it is definitely in the upward region. Second, because it is a occlusion of the LAD, definitely it is an anterior occlusion, so it is directed anteriorly. You can see it is directed anteriorly in the horizontal plane. It can be towards the right, can be towards the left. More frequently, it is towards the right. Okay, so that depends on the coronary anatomy, whether there is a septal predominance or a lateral predominance of the coronary supply. Most commonly, it is directed towards the right. It can also be directed towards the left. So what is the predominant takeaway from here is that this injury vector in the coronal plane, if you look at it in the coronal plane, that is this, there will be ST elevations in V1, leads V1, V2, V3, V4. Okay, it can go up till V4. So predominantly from V1 to V3, you have ST elevations. Now look at the corresponding ECG. In leads V1, V2, V3, you have prominent ST elevations that are seen here. Second important thing that will be seen is, if you look at now it in the frontal plane, if you look at it in the frontal plane, because this is here, this elevation is upwards, it is facing the AVR. Predominantly, if it is towards the right side, the AVR lead shows a ST elevation. So here you can see this AVR lead showing a ST elevation. Similarly, what happens is the reciprocal changes are there. So if this is the direction of the lead AVR, here is the lead 2. So you register a strong ST depression in lead 2. And in fact, ST depression in lead 2 is more than what is seen in lead 3, because the vector is oriented towards, the injury vector is oriented towards the right. So the reciprocal change is more towards the left. So you see ST depressions in leads 2 and 3 with 2 more than 3, also in AVF. And you also get ST depressions in V6, because that also lies in the negative hemifield of the injury vector. So very important clues here are ST depressions in 2, 3, AVF and V6, with prominent ST depressions in 2 more than 3. And remember, the sum of the ST depressions in 3 and AVF is more than 2.5 millimeter. That is strongly suggestive of proximal occlusions of LAD above the first diagonal. We'll come to that in the algorithm, this point that I just mentioned about the ST depressions in 3 plus AVF being more than 2.5 millimeter. And important thing that is very specific for occlusion above the S1 branch is that, so the point here is that the point I'm trying to make here is, and if you will just allow me to help you understand it, is that there are certain ECG characteristics which help you identify whether an occlusion is proximal to S1 or whether it is proximal to D1. So whether the diagonals are involved or not, or whether the septal branches are occluded or not. So the characteristic finding for an occlusion that is proximal to the D1 is 3 plus AVF ST depressions being more than 2.5 millimeter. That is characteristic of proximal occlusion of LAD above D1. Whereas if you have ST segment depressions in V6 with ST segment elevations in AVR and V1, what did I just mention? ST segment elevation in AVR and V1 plus ST depressions in V6. If this is more than equal to 0, that is suggestive of ECG occlusion proximal to the septal branches. So in this case, both of these criteria is met. It is proximal to both S1 and D1. So you will get occlusions. So you will get ST depressions in 3 and AVF, which are more than 2.5 millimeter. Along with that, you will get ST elevations in AVR and V1 and ST depressions in V6. The clincher point here is that AVR, V1 and V6 are the most important leads to look at for a proximal LED occlusion, and this V6 ST depression is a very, very important underscored thing in a ECG finding. So this is how we are looking at it for the proximal LED occlusion. Sometimes the anterolateral part is involved more frequently and it is the more involved part. In those cases, the elevation in AVL will be more predominant. So just imagine it in this way. If it is septal predominant, the ST elevations will be more in AVR. Whereas if it is lateral predominant, the ST elevations will be more in the AVL. So the ST elevation, the degree of ST elevation in AVR and AVL will be reciprocal to each other, and that depends whether the coronary anatomy is having an anteroseptal dominant involvement or an anterolateral dominant involvement. ST elevation, if it is if there is a high septal involvement, sometimes ST segment elevation in V1 is minimal. That is because the superior part of the septum is having perfusion from the RC also. So sometimes there is sparing of that proximal part because that region has double perfusion. So sometimes you may not get very prominent ST elevation in V1, and that is the explanation for it. Now we can just have a small look at the coronary angiographic view where you are able to look at the left main coronary artery giving rise to the left anterior descending and the LCX. So this is the left anterior descending that is seen into view, and as you can see there is a proximal occlusion, and after successful percutaneous intervention you get flow in the left anterior descending artery. You can see here it is very thin, and here you can see everything is well perfused, including the septal branches which are going inward. So this is sometimes mentioned. This is a TIMI flow 3. So what happens is there are reporting methods of the success of reperfusion, and the TIMI is one of the classifications that is used. Anyway, that is not relevant to us at the postgraduate level. So that is how the pre and post coronary angiographs look like. Now going to, so we'll go more quickly through the remaining occlusions. So if you will just allow me to give you a, a schematic understanding of how we shall be proceeding. So this was your proximal occlusion where the injury vector was here. In mid it will come like this, and in distal it will come like this, because in the distal more inferior part of the left ventricle is involved. So now look at mid LED occlusions. The vector here is directed upwards, slightly more towards the left. In the same is what you see in the horizontal plane. ST elevation in V1 has almost disappeared. Mainly it is ST elevations in V2, V3 and V4. Predominant ones you can see here are ST elevations in V2, V3, V4. So V4 ST elevation is very predominant. So V1, V2, V3, V4 ST elevations. There is no ST depression in V6. There is no ST elevation in lead V1. Apart from that, there are reciprocal changes in 2, 3 and AVF. You have ST depressions, and as I told you that in case of an occlusion that is distal to D1 and mid LED is proximal to D1 and distal to S1. So septal sparing, that means V1 ST elevation will not be there, but the diagonals are still involved. So 3 plus AVF will be more than 2.5 millimeter. The ST depressions in 3 plus AVF will be more than 2.5 millimeters. And you can see a labeled image here where if you look in closely, this here is the S1 branch, this here is the D1 branch, and they have shown you that the occlusion, the level of occlusion is between S1 and D1. And after reperfusion, you get TIMI3 flow. So injury vector is forward, upward and somewhat towards the left. No ST elevation in V1, no ST depression in V6. You get prominent ST elevations in lead 1 and in AVL because here it is towards the left side. So lead 1 and AVL will have ST elevation. Whereas you get ST depression, and here remember ST depression in lead 3 is more than lead 2 because now the injury vector is more towards the left side. So the reciprocal change will be towards lead 3, not towards lead 2. So ST depression in 3 is more than 2 in this case, and the high part of the septum is obviously not affected. Whether the apex is involved or not, it depends whether the LED is short or long. Most of the times the LED is long, so in 80% of the cases the apex is involved. Now going to a distal left anterior descending occlusion. In a distal occlusion, as we already discussed, it is the inferior part of the wall that is involved. So you get an injury vector which is directed downwards. Okay. So just imagine this to be flipped. This is the left side. This is the left ventricle. The inferior part is involved. The injury vector is downwards. So you get what do you get? And it is towards the left. It is definitely towards the left. So area at risk here is the inferior third of the left ventricle. Injury vector is obviously anterior and towards the left, but not upward. Because of this, what happens is, as usual, you get ST elevations in your precordial leads, V1, V2, V3, V4, but you also get ST elevations in leads 2, 3, and AVF. That is the clincher here. So when you see ST elevations in 2, 3, AVF and V1, V2, V3, V4. So you can see here almost 7 leads. Even V5 here is showing ST elevation. Almost V6 here is also showing ST elevations. So if you see ST elevations in 7, 8, 9 leads, you might think, okay, this is a extensive infarction of both anterior wall and the inferior wall. But you should imagine that such infarctions are not compatible with life. Such patients will not present to you. There is no ST elevation of AVR. So in these cases, you are forced to rethink. And this is likely a distal left anterior descending occlusion where you get ST elevations in both the inferior leads and the precordial leads. But the ST elevations in precordial leads is more than the inferior leads. So injury vector is anterior and towards the left, but never upwards. If it is a long LED, the injury vector is directed downward, and that is usually the case. And in AVR here, you will also see slight ST segment depression. That is a reciprocal change. As you can see here, AVR is opposite to this injury vector. So you get a reciprocal ST depression in lead AVR, whereas proximal occlusions go on to show a ST elevation in AVR. Okay, so AVR is also an important thing here. And if the LED is very short, infarction is distal to S1 and D1, there are sometimes you might not get any segment elevations in the precordial leads. In fact, inferior lead changes sometimes may be the only things that are seen. Now we talk about two more rarer cases. So we have discussed the proximal, mid and distal LED occlusions. Now talking about selective occlusions of the diagonals. That is occlusion of the D1 and D2 and S1 and S2. So if you have a selective occlusions of the diagonals, the basically the mid-low part of the anterior wall and the low lateral wall is involved. But the basal part of the lateral wall, that is this part of the lateral wall, is spared because it is supplied by the left circumflex artery. You will see this in the obtuse marginal occlusions. So now as a result, the injury vector, it is directed upward, forward and leftward. Upward, forward and leftward. So the changes that you will see here will be ST segment elevations will be there in leads 1, leads AVL, because it is upwards and leftward. And in the precordial leads, you will see elevations from going from V2 to V6, and you will see corresponding ST depressions in 2, 3 and AVF, with lead 3 showing a stronger ST depression as compared to lead 2 because that falls in the negative hemifield. And sometimes you can get ST depressions in V2, V3 that we'll talk about when we talk about multivessel occlusions. Okay, and it was classically considered that this lead AVL faces the high lateral wall. But now that concept has changed, and the high lateral wall is in fact perfused by the LCX. We'll discuss about that in the LCX occlusions. Coming to occlusion of the septal branches. So when the septal branches are involved, we already discussed the septal area of the myocardium is at risk. And what you can imagine is that the heart is a single cavity of the left ventricle. If the septum is gone, the injury vector is certainly towards the right side. Injury vector is certainly towards the right side. The septum is somewhat present upwards. So septum is injured means right and upward. So right, upward and forward, anterior, upward and rightward injury vector affecting the septum depending on the number of septal branches that is occluded. So what do you get? Classically, you get ST segment elevations in V1, V2 and AVR because these are the right facing leads. Along with that, you get ST depressions that are present more predominantly in the lead 2. So 2 more than 3. And remember here, you do not get any ST elevation in case of AVL. Even V6 might show a small ST depression. So isolated occlusion of ST, because it is proximal to S1. Remember one criteria that we talked about, ST elevation in V1 plus V1, ST elevation in V1 plus AVR plus the ST depression in V6 will be more than equal to 0. So as you can see here, what is going to happen is there will be ST elevation in lead V1. About 3 millimeters of an ST elevation is seen here, as we talked about. Along with that, in lead V2, we are able to register an ST elevation. In leads AVR, we are able to see an ST elevation. That is in the 12 lead ECG. Reciprocal ST depressions. So you can see ST depressions predominantly here in lead 2, even in lead 1, you can make out an ST depression. Lead AVL shows an ST depression. And even the distal leads, the V5, V6 have ST depression. So sorry, reciprocal changes here in leads 1, 2, AVL, V5, V6, you are able to see. That is on a standard 12 lead ECG. So oftentimes the 12 lead ECG is enough to diagnose all kinds of myocardial infarction. The concept of taking 15 lead or 18 lead ECGs, taking right sided lead, posterior leads is often not required. In fact, it has been shown that sensitivity and specificity of a 12 lead ECG is almost comparable to others, and it does not give additional information. But if you do happen to take the right sided leads here in occlusion of septal branches, the right facing lead is the V4R. So this V4R will have a ST elevation. So basically, it is said that this V1 lead can be taken as a surrogate of the V4R. Okay, so that is the concept here. One rare case that we talked about where the anatomical variant is present, where the D1 branch arises before the S1. So in this case, what happens is occlusion is proximal to S1 but distal to D1. Again, this will be what we already discussed. If the occlusion is distal to D1, you will have one very important criteria, that is that is leads to uh, two important things. One, the occlusion here in this case is distal to D1 and proximal to S1. Remember, whenever it is proximal to S1, you register ST elevations predominantly in leads AVR and V1 and ST depression in V6, as is seen in this case. So what this pattern is called is, so if you describe it in the form as an interventional cardiologist, you will say that the coronary angiogram reveals a non-classical branching pattern of the LAD with early diagonal takeoff, and the injury vector in this case is towards the right because the septal branches are occluded. So as we discussed in septal occlusion, it is anterior, it is towards the right, and sometimes it is downward. Sometimes it is downward because it behaves like a distal LAD occlusion because the diagonals are spared. So the injury vector is downward as compared to a isolated septal occlusions. Okay, as a result of which what happens is the features of distal LAD occlusion are seen. Remember, in distal LAD occlusions, you had ST elevations in leads 2, 3 and AVF. So in this case also you get ST elevations in leads 2, 3 and AVF with ST elevation in lead 3 being more than 2 because it is towards the right side. So ST elevations in leads 3 more than 2 and AVF with ST elevations in AVR and V1 with ST depression in V6. Even V1 to V4 you will have ST elevations. So compare this to a distal LAD occlusion where you had features of only the distal LAD, but you did not have ST elevation in AVR V1, you did not have ST depression in V6. So this is the catch point here. With that, we come to an end of left anterior descending occlusions. That was your anteroseptal infarctions. Those are the anteroseptal zones of your myocardial infarction. After that, we move on to the inferior wall MIs. That is the RCA and the LCX territories. Now we shall quickly go into the approach of localizing inferior wall MIs. One fundamental concept to establish early on is whenever you look at inferior wall MIs, you are looking at elevations in the inferior leads. ST elevations in leads 2, 3 AVF. A word of caution, even distal LAD occlusion can have ST elevations in 2, 3 AVF, but the ST elevations in precordial leads will be the more prominent ones. But when you see prominent ST elevations in the inferior leads, you should think about an occlusion of either the RCA or the LCX. So what you should get alerted to is that in this case, the very helpful lead here for you guys is going to be the lead 1. The standard 12 lead ECG lead 1 is going to be the most useful lead. So if you just will allow me that this is the case. Without knowing details of the anatomy, you can just imagine that the left circumflex supplies the left side and the right coronary artery supplies the right side. what happens here is the lead 1 is facing this part of the heart. This is how the lead 1 is oriented. So if you have an occlusion of the LCX, your injury vector here, it will be directed towards this side. Whereas if you have an occlusion of the RCA, the predominant injury is on this side. Imagine the injury vector is directed like this. So in one case, its frontal projection. In the frontal plane, its projection is facing lead 1. So in ST elevation, in lead 1 will be seen in case of LCX. Whereas RC occlusions, this vector is facing away from lead 1. In that case, you will get a corresponding change of an ST depression in case of the first lead. So that is what is represented here in this diagram. In both cases, you have inferior leads ST elevation. Whereas in case of RC occlusion, you get ST depression in lead 1. Whereas in case of LCX occlusion, you get ST elevation in lead 1. So lead 1 becomes the clincher. Now the concept here is that inferior wall MIs can either localize to the right coronary artery or the left circumflex. As we discussed, they can be, in case of the left circumflex, they are either proximal to the obtuse marginal or they are in the obtuse marginal, and that is, they're not involving the proximal part of the left circumflex. Some features of right coronary artery. So right coronary artery gives predominant supply to the right ventricle through its acute marginal branch. The posterior wall, okay, the posterior wall, that is the basal part of the heart, is also supplied by the right coronary artery, because in 90% of the cases it's a right dominant circulation. So the posterior descending artery arises from the posterior wall, so from the right coronary artery. As a result, if there is involvement of the right ventricle, or if there is posterior wall involvement on the 12 lead ECG, it is considered to be an occlusion of the right coronary artery by default. So just see what I'm telling here. When you are looking at an approach to inferior wall MIs, first you should see whether there is right ventricular extension or posterior ventricular extension. If it is present, your localization automatically is the right coronary artery. Supporting evidence will be lead 1 will have ST depression. Whereas other possibilities you have to look at, and if there is ST elevation in lead 1, that is a definite clue that it is a left circumflex artery occlusion. That is how you can localize to these two arteries. Now we shall have a look at their individual case scenarios going from artery to ECG. So first is the RC occlusion, that is proximal to an RV branch. So it is a proximal occlusion of the right ventricle. This, just imagine, so proximal occlusion of the right circumflex artery, which also involves the right ventricle. So you can imagine your injured myocardium includes the right ventricle that is involved, and posterior one third of the septum is involved. So your injury vector is towards the right, it is directed inferiorly, and it is, so injury vector is downward, inferiorly, and also it is posteriorly, because the complete RCA is gone. So posterior descending artery is gone. So injury vector is directed posteriorly. So far, all of our occlusions had anteroseptal zone occlusions, right? Anterolateral or anteroseptal. So everything was anterior. Now, this is the first time that in the horizontal plane, we are going backwards. We are going posteriorly. Second thing that we are doing is we are going rightwards. Third thing that we are doing is we are going downwards. So downwards, posteriorly, and to the right. As a result of which, there are very interesting ECG findings that you get in a proximal RC occlusion. Because it is towards the right, you have ST elevations in V1. And if you are taking V4R, that is also there. So V1 is a surrogate of V4R. So you get ST elevation in V1. Second thing, it is downwards. It is downwards. So obviously you get ST elevations in leads 2, 3 and AVF, with ST elevation in lead 3 being more than in lead 2. Okay. So you can see here also ST elevations in lead 3, 2 and AVF. ST elevation in lead 3 is more than lead 2. Apart from that, ST elevations in leads V1, V2. That is what you are getting. So ST segment elevations here, and you get ST segment depressions in leads V6, because it is in the negative hemifield of this vector. So V6 generally has slight ST depression, and also in 1 and AVL you will get negative changes. So if you look at the reciprocal changes, you get 1 AVL and V6 ST depressions. Apart from that, ST depression in V1 to V3 is not seen. Okay, and here you are in fact getting ST elevations, because um, in other cases you will see that the precordial leads. So what is expected here is, typically what you expect is V1, V2, V3, these are precordial leads. So you expect if 2, 3 and AVF are having ST elevation, you will expect them to have ST depression. But if you are seeing an ECG which is having predominant inferior lead ST elevations, but even V2, V1, V2, V3 have slight ST segment elevations or they are isoelectric, that means it is towards the right side. That indicates some right ventricular involvement. So because of that, you are able to differentiate that this is a proximal RC occlusion, which means right ventricular wall is also infarcted. Along with that, possibly the posterior wall is also infarcted. So this is a case of the proximal occlusion. Other point is that this occlusion in V4R, it is considered, it is only seen in the hyperacute phase. So it is a very transient occlusion. So if you get a patient who is presenting in within 12 hours, usually seen, it is seen between 4 to 12 hours. So if you are seeing a patient in this phase, you might be able to see that. But that is why lead V1 is very important. Even if ST elevation is not seen in V4R, V1 will always give you the clue. So there is no need to record V4R separately. V1 is usually enough. And important point to remember is if it is involved, it will be in the hyperacute phase, that is in the 4 to 12 hours. In the evolved phase, these are not seen because they are transient. Therefore, if you get an ST elevation or even an isoelectric part in V1 during an inferior wall MI, that shows that right ventricular involvement is present. So for right ventricular involvement, your important lead to look at is lead V1. Correct? Now we go to a distal RC occlusion where you have sparing of the right ventricle. So in that case, you are having somewhat of an injury vector towards the right side. Now, since the right ventricle is spared, the injury vector shifts slightly towards the left. So the injury vector is still downwards, still slightly towards the right, but it is directed more downward than posteriorly. So you have a prominent downward involvement now. Okay, so if you look at this angiograph, in this part, you can see here, this is again your LAO view, that is a cranial LAO view. In this, you see a occlusion that is proximal to the marginal branch. Okay, and after revascularization, you are able to see the marginal branch and the rest of the RCA after PCI. In this case here, as you can see, the occlusion, the acute marginal branch has already been supplied. Okay, so the occlusion here is a distal occlusion, and after reperfusion, it restores, and the injury vector is directed somewhat downwards and posteriorly. Definitely it is downwards, definitely it is posteriorly, and slightly more towards the left as compared to a proximal RC occlusion, although it is still towards the right. So what you register here is uh, the important things is, since it is downwards, your classical ST segment elevations are seen in 2, 3 and ABF. Because it is RC, it will always be lead 3 more than lead 2. What happens here is, now you see what is the posterior wall involvement. Because the injury vector is directed posteriorly, you are not able to make out ST elevations because they will be seen if you are taking the leads posterior leads, the V7, the V8, V9, though they will show ST elevation. But as I said, we are only looking at 12 lead ECGs. We are not concerned about other ST segments or other leads. Okay, so instead of that, what we can look at is this negative tail will show ST depressions in V1, V2, V3 that are very prominent. So what you will see is 2, 3 and AVF will have ST elevation and ST segment depression in V1 to V3 leads, and this will show you a posterior wall involvement. So in this case, there is ST depression, and if you look at leads V3R and V4R, they will show a positive T wave, but there is no ST elevation because the right ventricle is spared. In this case, even if you take your V4R lead, it will show you a it will not show you any ST elevation. There will also not be any T wave inversion. We'll look at that when we come to the algorithm. Okay, so this is what you will go on to see. Now, one very important thing for us to differentiate is, if you look back here and you look at proximal RC occlusions, I told you here that you get ST elevations in both the precordial leads and the inferior leads. Remember when we discussed distal LAD occlusions, you had a similar pattern where you had ST elevations in 2, 3 AVF and ST elevations in the precordial leads, that is V1 to V4. So point being, how do you differentiate these two occlusions? So if you have an occlusion where you get ST elevation of 2, 3 AVF plus you get ST elevations of V1 to V4. There are two possibilities. It can either be a distal LAD as we discussed previously or a proximal RCA as we discussed now. So what are the important findings that you get? One, if it is a proximal RC occlusion, it means right ventricle is involved, and V1 was a surrogate of V4R, which means V1 will have prominent ST elevation. So ST elevation in lead 1 will be more than the V3, V4. That is one finding of proximal RCA, whereas in LAD it will be the opposite. Second thing, since proximal RCA injury vector is predominantly downwards, in both cases it is downwards. LAD it was this way and RCA it was this way. But remember, if it is an RCA occlusion which is proximal, which means larger area of myocardium is affected, so the ST elevation in inferior leads is more than that in precordial leads. Whereas in case of an LAD occlusion, the ST elevation is much lesser in the inferior leads. Last finding is the finding in 1 and AVL. So if you remember the leads in the frontal plane, here is lead 1 and here is lead AVL. So for a distal LAD occlusion, they will not have ST depressions. Whereas if it is a proximal RC occlusion, they come in the negative hemifield. They are reciprocal changes. So you will get prominent ST depressions. In fact, the sum of ST depressions in 1 and AVL is more than 5 millimeter in case of a proximal RC occlusion. So those are the important findings that you have to keep in mind for a proximal RCA versus a distal LAD. Okay. Now, so ST depression in these are very, very important and in leads 1 and AVL because they give you a very critical idea whether it is proximal RCA or distal LAD. And as you know, that localization is very important to us. Okay. Now we go to the last artery, that is the left circumflex artery. So left circumflex artery anatomy was with regards to the obtuse marginal. So you can have an occlusion that is either proximal to the first obtuse marginal, or you can have an occlusion that is present in the first obtuse marginal. So if you look at it again, LCX occlusion, it's an inferior wall MI, so leads 2 more than 3. Here the ST elevations in lead 2 will be more than lead 3. So you get ST elevations in leads 2, 3 and AVF with 2 more than 3 pattern, and you get ST depressions. Again, injury vector is posterior and left in the horizontal plane. So ST depressions are seen in V1, V2, V3, again related to your involvement of the posterior ventricular wall. So V1, V2, V3 are going to have ST depressions. So just as I told you one more thing, that usually posterior wall involvement is in the right ventricle, but this here case assumes that the left circumflex is a co-dominant or a balanced dominance is present. In that case, posterior ventricular wall is also getting supply. So V1, V2, V3 ST depressions here represents posterior ventricular wall involvement. You can see in the angiogram finding, there is a proximal LCX occlusion. There is almost no visualization of the LCX. Here, if you look at it, the LCX is almost gets cut off here abruptly, whereas after perfusion you are able to see the LCX. Again, this is a RAO caudal view, and you get injury vectors backward, downwards, towards the left, ST elevations in lead 2 more than lead 3, and ST depressions in V1 to V3. Sometimes these are the more prominent changes. Okay, sometimes these ST depressions in the precordial leads, particularly in lead V1, V2, these are up to 5 millimeters of ST elevations, and the inferior lead ST elevation in fact might be slightly small. Okay, we'll talk about a reason for this. The reason for this is very simple. So a non-dominant LCX, it usually bends upward. So predominantly it's not the inferior part that is being affected. It is predominantly the basal part, that is the posterior part, and somewhat the lateral part. So the inferior ST elevation might not be so prominent, but the ST depression, which is a reciprocal change of the posterior wall involvement, might become more prominent. Okay. So sometimes the only change that you might see will be ST depressions in V1 to V2, V1, V2, V3. And in those cases, you have to think that it can be an LCX occlusion. This will get more clear as we talk about occlusions that are proximal to the first obtuse. So that was occlusion proximal to the obtuse marginal. Now this is an occlusion of the first obtuse marginal. This is known as hidden MI or silent MI or blind spot of the 12 lead ECG. So classically, the high lateral wall involvement has always been of interest on 12 lead ECG. Okay. So basically, if there is only an occlusion of the obtuse marginal, the area of myocardium that is risk is predominantly this one, this area. So you know there are leads 2, 3 AVF which are facing here. Okay. Then you have leads AVR, AVL, 1 present here. Okay. So this area, only 1 or 2 leads are able to detect. And that also is a small area. So you might not get very prominent ST elevations in this. And these leads will also not be very sensitive to these changes. If you look at it in the horizontal plane, in that case also see V1, V2, V3, V4, V5, V6. It is almost coming at the level of V6. It is almost coming at the level of V6 or even somewhat more posteriorly. So these precordial leads are also not able to register this MI. As a result of which, if you look at the injury vector, it is somewhat more posteriorly as compared to V6. So slight ST segment elevation in V6. And if you look at it, it is neither upward nor downward. So there is no prominent upward or downward pattern. Only benefit of that is in lead 1, sometimes you might get a small ST elevation, or sometimes in lead AVL. But here also, as you can see, it is not very prominently seen. 1 and A will look relatively normal. Only thing is V6 is having some ST elevation. So V5, V6, you should be very alert. If you get elevations in V5, V6, there can be an occlusion of the first obtuse marginal, and that might be a silent MI on ECG. Patient will have chest pain. Patient will have all those findings. It's not a silent MI in terms of clinical presentation. It's a electrographically silent MI. As you can see here, the obtuse marginal branch appears occluded in this case, and after reperfusion, you will get a occlusion here. One more importance of this is there is a small anatomical variant. This first obtuse marginal branch sometimes arises as a separate coronary artery called as the ramus intermedius. It is called as the third coronary artery, and essentially it is behaves like the obtuse marginal. And sometimes, even if it is not anatomically present, if that obtuse marginal branch is very predominant, the cardiologist will call it the ramus intermedius, electrophysiologically. Okay, so this area is shared with the ramus intermedius. Then it is a high lateral wall MI, which is the blind spot. Injury vector is left, somewhat posterior. Sometimes can be upward, sometimes can be downward, or it can be neutral. Main ST elevations in 1 AVL, V5, V6. Sometimes you get inferior lead ST elevations in, because somewhat it can be downwards, you can get in 2 at AVF. Okay, so that is the pattern here for the MI. Now this is a hand-drawn image by me summarizing what are the various ST segment elevations and depressions that you can see in a image. So if you look at it, you have the RCA, you have the LCX, and you have the LAD. If you look at RCA, the approach is whether it is proximal to the acute marginal or distal to the acute marginal. What do you get in each of the cases we are going to discuss? In a short summary, occlusions of the RCA proximal to this. So this was the acute marginal branch supplying the right ventricle. If it is proximal, you get important thing that you get here is you will get a V1 which is isoelectric or a ST elevation in V1 showing there is right ventricular involvement. Whereas if it is distal to the acute marginal, the right ventricle has already been supplied, so that change is not present. Apart from that, all RCA occlusions lead 3 ST elevation more than lead 2 because that is more towards the right side. Apart from that, ST depressions in 1 AVL, and if it is distal, you can also get ST depressions in V1 to V3. If it is a left circumflex artery occlusion, you get ST elevations in V5, V6, one more than AVL, and inferior, you also get 2, 3 AVF. It is a proximal occlusion. Because of the involvement of the posterior wall, you get ST depressions in V1 to V3. Subtle part is a obtuse marginal occlusion where you get minimal ST elevations from 1 AVL, V5, V6, sometimes even 2 and AVF, ST depressions in V1 to V3. Left anterior descending, multiple times we have discussed proximal, mid and distal. In case of proximal, you get ST elevations in V1 to V4, that is the predominant uh, leads of the precordium. But more importantly, you get ST elevation in AVR and you get ST depression in V6. So remember the clincher for occlusion proximal to the S1 was ST elevation in lead AVR and V1 and an ST depression in V6. Apart from that, ST depressions in 2, 3 AVF are seen. Okay. So pardon me here that this V6 is an ST depression. Then if it is an isolated septal occlusion, again same thing V6. Again you will get V1, V2 AVR ST elevations and V6 ST depression. So V1 and AVR ST elevation and V6 ST depression tells you that the occlusion involves the septal branches. Then in a distal occlusion, you get ST elevations in all the leads, precordial leads and inferior leads. And remember, we discussed even though you are getting ST segment elevations in so many leads, it is actually a MI which is better than a proximal LAD MI because that involves a greater part of the myocardium. So more ST elevations does not mean worse MI. That is the important takeaway. Then you get a mid occlusion in which you have V2, V1, V5, V1 AVF ST elevations and 2, 3 AVF ST depressions. Last is your diagonal part in which 3 more than 2 ST depression and 1 AVL, V2, V5 ST elevations. This we have already gone into in quite detail. Important takeaways, surrogate for V4R is V1. So if V1 is involved, you are pretty sure right ventricle is going to be involved if there is inferior lead ST elevation. So addition of the extreme right precordial leads or posterior leads very slightly it will increase the sensitivity, but mostly your 12 lead ECG will suffice. Okay, so that is going from artery to ECG. Now we shall do what is practically required. The practically thing that is required is going from the ECG to the artery. That is what you are going to be doing in your clinical practice. So now we shall synthesize all of this into an approach from artery to ECG, from ECG to artery. So first thing that you will look at is whether there are ST segment elevations in the precordial leads. So precordial leads means if there are ST segment elevations from V1 to V6, V1 to V6, anywhere. It can be from V1 to V4, it can be from V2 to V3, something like that, V2 to V4. Then you have to think about occlusions of the left anterior descending artery. The first thing to check in this case is whether there is ST segment elevation in lead 2, 3 and AVF. So imagine if there are reciprocal changes in 2, 3 AVF versus there are elevations. As I told you, if there are elevations, that means that it is distal to D1. It is occlusion is distal to D1. ST depression is not present. There are in fact either the ST segment is isoelectric or it is having elevation. So this is your case here when you get elevations in both precordial leads and inferior leads. So occlusion is distal to D1. Usually D1 is also distal to S1. So that obviously means it is a distal LAD occlusion unless there is a variant of the anatomy. The other part of the algorithm is whether to look at the ST segment depression. If there is reciprocal changes, and remember these reciprocal changes criteria wise, the ST segment depression that is expected is in lead 3 plus lead AVF, this ST segment depression, if it is more than 2.5 millimeter, this finding has a very high specificity of the occlusion being proximal to D1. This will signify occlusion is proximal to D1. Okay, so you can see here ST segment depressions. And after you have localized with regards to D1, so what you are doing here is you are first seeing whether the occlusion is proximal or distal to D1. If it is distal to D1, you will see ST elevations in 2-3 AVF. If it is proximal to it, you will see ST depressions of more than 2.5 millimeters in lead 3 and AVF. Now you want to see whether it is proximal to S1 or distal to S1. Now with regards to S1, you have to find out whether septal involvement is present or not present. In that we already discussed, that is characterized by if the ST segment elevation in AVR plus V1 plus the magnitude of ST segment depression in V6 is more than equal to 0, occlusion is proximal to S1. If this whole summation is negative, if this becomes negative, it is distal to S1. Okay. Other possibility is other possibility that you can often find on 12 lead ECGs, which is somewhat a direct hint, is that if you look at the supply of the right bundle branch block, if you look at the supply of the right bundle branch, most of the times it is supplied by the septal branch of the LAD. So if this gets involved, if you get a right bundle branch block, that also signifies that it is a left anterior descending involvement. In fact, because of this, you will get what is a right bundle. So basically, if you are getting a right bundle branch, your right bundle branch is getting affected as a conduction abnormality. You will get to see on your 12 lead ECG a right bundle branch block, RBBB. So because if you remember in the evolved phase of MI, you get Q waves. Q waves represent an evolved MI. So you get a QRBBB pattern that represents a occlusion that is proximal to S1. So proximal LAD occlusions, there are two things to look at. One, whether there is a QRBB pattern or whether there is a ST elevation in V1 plus AVR plus the ST depression in V6, whether it is positive. These are the findings for a proximal LAD occlusion. So occlusion proximal to S1. Okay. Note very carefully here, there is a scenario here where the occlusion is proximal to D1 and proximal to S1. But remember one rare variant of the coronary anatomy where the D1 arises after the normal is S1 followed by D1. If it is opposite, that is the D1 arises before the S1, the occlusion is proximal to S1 but distal to D1. So that will be this case where you have a variant of the coronary anatomy. Okay. And remember here, one important point is that in cases which have a ST depression of less than 2.5 millimeter here, they are difficult to classify in respect to D1. But this criteria is always holding. Okay. So that is about an approach to how you uh, deal with precordial lead ST segment elevations. So even cases with involvement of the left main trunk that present as huge ST depression may show STEMI if there is no previous collateral circulation. This is one point we'll touch on later. And when the ST segment is isoelectric in 2-3 AVF, the occlusion is distal to D1. And you should further look at AVR V1 V6. AVR V1 V6, if this criteria of summation is satisfied or if there is a new onset RBB, you will be able to get a occlusion proximal to S1. Sometimes you get an early diagonal takeoff in a non-classical branching pattern of the left anterior descending, and the S1 takes off after the D1 branch. So the occlusion has features of both being distal to D1 and proximal to S1. So that is the important takeaway from these slides. Okay. Now, one thing that we have discussed here is the QRBB, which localizes to proximal LAD. So just have a look here in the ECG. So how do you pick up right bundle branch block involvement? So our classical mnemonic for that is Marrow and Williams. So if it is a RBBB involvement, okay, you will get a M pattern in lead V1 and a W pattern in lead V6. So here you can very well make out the M that is formed here and the W that is formed here. So an M and a W is seen, so it is a right bundle branch block pattern and you are able to make out Q waves. So indeed the occlusion here should be proximal to LAD. Right? Other findings that you can see here are AVR ST elevation is present, that also localizes proximal to LAD. So it shows high septal ischemia occlusion is above the S1 and the right bundle branch block is being occluded. So in this case, you will do a PCI to the proximal LAD. Now that was the approach to precordial lead ST elevation, which remember, even if you have a ST elevation in 2-3 AVF along with a precordial ST lead elevation as is seen in distal LAD, you should follow the algorithm above. Now coming to ST elevations in inferior leads, that is if you see ST elevations in 2-3 and AVF. ST elevations in 2-3 AVF take you to either an RCA or an LCX occlusion. That is very clear. So these are all inferior wall MIs which you want to localize either to the right coronary or the left circumflex. Then you will look at the V4R lead. You will look at the lead that is V4R, whether it is available with you or not. Most of the times we assume it is not available to us. Just a small scenario in case you have a V4R lead. The caveats here to remember are, first of all, the ST elevations in V4R are transient. So it is only helpful if the patient has presented between 4 to 12 hours. So you should not look at V4R elevations in a patient who had an MI 2 days back. Okay, in that case, this might be misleading. But in a patient who has a transient in the hyperacute phase of the MI, he has presented to you clinically, then you can look at the V4R lead. And if you see an ST elevation in V4R lead, it definitely gives you a clue that the right ventricle is involved. As I told you, if right ventricle is involved, it is always the RCA. Okay. Now, if there is no ST segment elevation, that means right ventricle is spared. That means either it can be a RCA occlusion that is distal to the right ventricular branch, or it can be a left circumflex occlusion whereas the right ventricle is not getting affected. That how do you decide? You decide whether T waves are inverted or upright. If T waves are upright, it is a distal RCA occlusion. If T waves are inverted, it is a left circumflex occlusion, because in this case there is a reciprocal T wave inversion. However, if you have a patient who is either beyond 12 hours or there is a V4R lead is not available to you on an ECG, which will usually be the case, you will look at the segment 1. See, we have already discussed this concept before, that the lead 1 is very important in localizing inferior wall MIs to RCA or LCX. In RCA, you will have ST depression in lead 1, and LCX you will have ST elevation. Sometimes, however, it may be isoelectric. So now you look at this. If there is ST segment depression, straightforward you call it RCA occlusion. If there is ST segment elevation, you straightforward call it LCX. Your doubt comes when it is isoelectric, and that is where the Fiol algorithm comes into use. So if this is isoelectric, then you look at whether ST elevation in 2 is more than 3 or 3 is more than 2. Remember, 3 more than 2 is RCA and 2 more than 3 is LCX. Why? Because this here is lead 2, this here is lead 3. Lead 2 is towards the left, lead 3 is towards the right. So if 3 more than 2, it is the right coronary. If 2 more than 3, it is the left circumflex. So just a further simplification of the same criteria, if you go into, you will come to see if it is ST elevation in 2 is more than 3, you straightforward call it LCX. If that criteria is not met, one other useful feature was whether ST depressions in V1 to V3 are present. That indicates that the inferior wall, the posterior wall is being involved. So if the ST depressions in leads V1 to V3 are more prominent as compared to the ST elevations in 2-3 AVF, that means their ratio is more than 1, it is in favor of LCX, whereas if that is not the case, it is in favor of RCA. You can look here. Here, ST depressions are not so prominent, whereas the ST elevations are very prominent. That is the case of RCA. Whereas, if the ST elevations are not so prominent, but the ST depressions are very prominent, that is the case of LCX. So that is the Fiol algorithm for differentiating between inferior wall MIs, RCA versus LCX occlusion. So ST and T is important in V4R. Sometimes it is not recorded and the abnormalities are transient. So sometimes it may even be misleading. So lead 1 is the more reliable lead for differentiating between LCX and RCA. If lead 1 gives you isoelectric, if it fails you, then you look at whether ST elevation is more in 2 than 3. If that is the case, it is LCX. Otherwise, you look at whether ST depressions are more prominent than the inferior lead ST elevations. If that is the case, it is still left circumflex. If that is not the case, then you go to a right coronary artery occlusion. Then you can find out whether it is proximal or distal to the relative branches as we have discussed. So that was the approach to ST elevation in precordial leads, ST elevation in lateral leads. So V1 to V6 is covered and 2-3 AVF is covered. Some other approaches that are not given classically in textbook is ST elevations in the lateral wall leads. So if you get ST elevation in 1 AVL V5 V6, so remember these are the lateral wall leads, and as we discussed, this is the silent wall, silent region of the MI. So you can get 1 AVL V5 V6. So remember this is of course in the frontal plane and this is in the horizontal plane. So if you get this pattern of an ST elevation, it can either be due to D1, D2 occlusion of the LAD or left circumflex, it can be obtuse marginal occlusion or it can be a ramus intermedius occlusion. So if it is a isolated occlusion of the diagonals of the left anterior descending, you will get ST elevations in V5, in V6, V1 and AVL. And in inferior leads here, you will get ST depression because remember, this is the left anterior descending. So prominently, the injury vector will be upwards. So inferior leads will have ST depression. Whereas if it is localizing to the left circumflex artery, which is usually an inferior wall MI, you can get slight ST elevations in inferior leads. However, that is only sometimes. Sometimes you can get only minimal ECG changes in the form of a posterior injury vector, where the ST depressions in V1 to V3 will be more prominent than the inferior elevations. So that gives you a clue whether it is a diagonal occlusion or an obtuse marginal occlusion, which is giving you the elevations in the lateral wall leads. Last is a ST deviations in AVR. That is very, very important to understand that AVR ST deviations, that is ST elevation in lead AVR is a dangerous sign. ST elevation in lead AVR localizes to, so if you have an ST elevation which is more than equal to 0.5 millimeter with ST depressions in 8 or more leads, it signifies an incomplete occlusion of the left main coronary artery, or it says that there is global ischemia, so it can be triple vessel disease. So ST elevations of more than 0.5 millimeters in AVR are very, very important. So approach to ST elevation in AVR, you should also look at lead V1. You should also look at lead V1. So if ST elevation in AVR is more than V1, it favors a left main coronary artery occlusion, which is very dangerous. Often patients who have a left main coronary artery, just imagine left main coronary obstructed. Your LAD is gone, your LCX is gone. It's an anterior plus inferior wall involvement. Everything is gone. So usually such patients will not make it to the hospital. So that is why most of these patients will die. But if they do make it to the hospital, it is very important for you to recognize them early and send them to the cath lab early. So AVR more than V1 means LMCA, and V1 more than AVR, remember we discussed proximal LAD occlusions where V1, AVR and V6 are very important. So here also you can see V6 is having ST depressions. So V1 more than AVR tells you it is a proximal LAD occlusion. So that is the approach to ST elevations in AVR. So basically AVR and V1 go hand in hand. AVR and V1 go hand in hand, and you should be looking at both of them to decide what kind of a disease is there. Other possibility of ST elevation in AVR. So that so this thing, when I knew about this thing, it often creates some degree of ST elevation anxiety in a person. Okay, so whenever you get ST segment elevations, So the ST elevation in AVR anxiety, sometimes what can happen is, so basically nothing. Whenever you get an ST elevation in AVR, it means overall the heart is affected. It can either be due to an occlusion in the left main coronary artery, or sometimes what happens is, if there are multi-segment ST depressions, it can also be a non-occlusion myocardial infarction. It means there is a global state of ischemia. For example, there is severe shock, there is severe anemia, in which case it's not about a thrombus or an occlusion in the artery. It's about, in general, the heart has lost its blood supply, or the heart is not getting enough blood. So they can lead to sudden cardiac death often if it is an occlusion. Your left main coronary artery occlusion, they will not reach the hospital. They will have a very dramatic presentation. So if you have a patient who is in severe shock or in the ICU and you get ST elevation in AVR, don't think of it to be a occlusion MI. Think of it to be a global, like your heart as a whole is not getting any blood supply. It's not related to the territory of any artery, but it is related to the fact that your heart is not getting enough blood supply. So there you have to focus on correcting the shock, correcting the anemia, whatever is the cause. So think of it as a type 2 MI. So deviations in AVR, as we discussed, if it is AVR more than V1, it is left main coronary. If it is V1 more than AVR, it is proximal LAD. One more thing, if elevations are seen in V1, remember one thing that we discussed of occlusions in LAD versus RCA. So RCA faces rightwards, so ST elevations in V1 are more than V2. Whereas if it is leftwards, ST elevations in V2 are more than V1. So if you look at the precordial leads going from V1, V2, V3, if you get an ST elevation which is more in V1 and it becomes lesser as you go down, that is a descending pattern. So if V1 ST elevation is more than V2, that means it is likely RCA. Whereas if you get an opposite scenario in which the V1 ST elevation is minimal, V2 is more, and V3, V4 are very prominent, that usually signifies a left anterior descending or an anterior MI. So ascending pattern of ST elevations in the precordial leads is due to left anterior descending artery, whereas sometimes due to right wall involvement you get ST elevations in V1 and V2, that signifies RC occlusion. Even isolated septal involvement you can get V1 occlusion. So these are the cases where AVR and V1 elevation are important. I thought to discuss this since it is often relevant. Now, one more small thing, that is posterior wall MI, also called as a STEMI equivalent. Why is it called as a STEMI equivalent and why not a STEMI? So if you're looking at the 12 lead ECG, in posterior wall MI, what will happen is it will mainly be the leads V1, V2, V3, V4 that are affected. Okay. So this here, what you're looking at is an inversion. You're looking at here is an inversion. Now have a look. Now this ECG is the way it was. Okay, so you see here that leads V1, V2, V3. They are having prominent ST depressions, which are horizontal ST depressions with associated upright T waves. And that almost always indicates that it is the infarct-related artery is the right coronary artery because it supplies the posterior wall of the heart using the posterior descending branch. Sometimes it can also be the left circumflex. So these are not reciprocal changes. They are changes of a posterior wall myocardial infarction. It is not a classical STEMI because your STEMI says more than 1 millimeter ST segment elevations in contiguous leads or some separate criteria for V1, V2 are given. So because it does not satisfy those conventional criteria, it is called as a occlusive MI, which is a non-ST elevation, but it definitely shows that there is an occlusion and you should take it up for PCI. Okay, so what you see here are horizontal ST depressions. The R waves are very tall. Actually, here the preceding R waves are very tall. The T waves are all upright. All T waves here are upright, and the what they say here is that in V2 you look at the R to S ratio, it is more than 1. So the R wave is prominent, R to S ratio in V2 is more than 1. So it is these are all findings that suggest that it is a posterior wall MI. So the easy way to look at it is in a 12 lead ECG. Of course, if you are taking posterior leads, they will show ST elevations. Like I told you, these are often transient. These are often not well appreciated. So if you look at the posterior leads, there is definitely ST elevation, which indicates that this is indeed representing an occlusion of either the RCA or the LCX. Sometimes other changes. So in this case, you are able to make out changes in lead 2 also, ST elevations, some ST elevations in lead 1 also. So here you are able to identify, but sometimes posterior wall MIs may only have these ST depressions. So it is very important to look at lead V1 to V3 to look for a STEMI equivalent. So one easy way to do that is, let's say you do not have these leads available to you. Let's say the posterior leads are not available to you, which will mostly be the case. So in that case, what you should do is you should take the ECG in your hand and flip it and invert it. Flip and invert, which is essentially what you will do is you will get a mirror image. Let's just do that here on this slide. So if I do that here, I have just now flipped the ECG. And if you look at it, you are able to make out, again, now focus your attention on leads V1, V2, V3, you are able to make out there are ST segment elevations. So what was seen as ST segment depressions on the mirror image. So that's why we talked about the ST segment depressions being horizontal, the T waves being upright. All those things were in context of how it will appear when it is inverted. Okay. So that is about posterior wall MIs. Now, one small concept of ischemia at a distance. This is a DM cardiology concept. This is perhaps not very relevant at the intern or the postgraduate level. So we'll only be briefly touching on this. We will not go into the details of why it happens. So what is the funda here? The funda here is that what people observed was that often there are ST segment elevations in some leads, mechanism of which we talked about is injury vector or injury current, and reciprocal changes, you get ST depressions. Some people told, for example, you get an ST elevations in 2, 3 and AVF. So expected reciprocal change is in V1, V2, something like that. But some people told that if you are getting along with this V1, V2, V3, V4, V5, V6, ST depressions in even in the lateral leads, not just in the anterior leads, then that indicates that these are suggestive of true ischemia at a distance from the occlusive artery. This means that there is a occlusion of one artery which is represented by this, but these additional ST depressions represent true ongoing ischemia at a distance from the infarct area. So this represents a multi-vessel disease. So this is the concept of ischemia at a distance. How I like to think of it is that there is an ST elevation MI of, let's say, the inferior lead. So let's say it is an ST elevation MI of the right coronary artery plus a NST MI of something else. Okay, so it is a STEMI plus a non-STEMI. That is the concept of ischemia at a distance. So it indicates a multi-vessel occlusion. So the first case that we were talking about, that if you have 2, 3 AVF ST elevations, it is acceptable to have V2 and V3 ST depressions. So that will usually indicate a right coronary artery occlusion. But if the ST depressions extend up to V4, V5, that usually means the LAD is involved. There is true anterior involvement. So that is a sign of N-STEMI of the LAD plus a STEMI of the RCA. Similarly, if there is ST elevation in the precordial leads, it is expected to have ST depressions in V5, V6. Okay, that means it is a left anterior descending. But even if the other lateral leads, that is the 1 and AVL, have ST depressions, that signifies multi-vessel involvement. Taking this concept a bit further on how you predict multi-vessel involvement is in the form of, think of a long LAD. A distal occlusion of a long LAD will be involving extensive part of the apex. Okay, that is also called as a wraparound LAD. Compare it to a short LAD but a chronically occluded RCA. So a chronically occluded RCA which is getting collaterals from this distal LAD. So an infarct of a long or a wraparound LAD will resemble chronically occluded RCA plus an occlusion of an LAD. So here also you will get elevations because large part of the inferior part of the apex is supplied and the left anterior descending is supplied. Distal LAD you will get elevations in both precordial and inferior leads. So a distal LAD occlusion can be due to which is extensive, can be due to a wraparound LAD, or it can be due to a short LAD occlusion with a chronically occluded RCA. That will be missed here. One more concept is if you have lateral lead elevation of 1 AVL V5 V6 with 2 3 AVF ST depressions, it usually means it is a T1 occlusion. Okay, but if those ST depressions are present in V2 V3 V4 also, then that signifies some true posterior wall ischemia is also present. That means usually T1 plus LCX or RCA depending on the dominance of the circulation. Even if you did not understand ischemia at a distance and multivessel occlusion, it is fine. We have not discussed it in too much detail. Okay, just imagine this. The leads V2, V3, V4, they are anterior leads. Okay, they are not reciprocal to the lateral wall. So it represents true anterior subendocardial ischemia. So it is anterior ischemia at a distance and implies that it is the left circumflex, or due to RC, it is global ischemic burden. Okay. So basically, point being, reciprocal changes are only expected in certain leads. If there are additional ST depressions or additional ECG findings, sometimes they are a clue to a multivessel occlusion which can be picked up on ECG. Now, going to a concept related to occlusion MIs or occlusive MIs. So we will keep it very short. Otherwise, we will have to go into the detail of each OMI pattern and its anatomy and its corresponding angiographic picture. But we will only limit our discussion to how the ECG patterns appear and what is the occlusion. So, what are occlusive MIs? So, there are certain patterns of myocardial infarction which do not fit your classical criteria of having ST segment elevation more than 1 millimeter in two contiguous leads. However, these also represent occlusions and they also need to be taken to the cath lab. So, these patterns have been identified over the years and the concept is evolving from ST segment elevation MI to occlusion MI. Okay, so these are non-ST segment elevation occlusion MIs which require urgent cath. So in that, the one which you see very commonly is the valence patterns. So pattern A is a biphasic T wave inversion and pattern B is a deeply inverted symmetrical broad T wave. So depending on which leads they are present in, they will give you an idea of where the occlusion is present. There is something called as the Wellen syndrome, which has other criteria regarding the relation to chest pain, regarding the trop values, and mostly Wellen syndrome means it is a proximal LED occlusion and you should immediately take it to the cath lab because a large area of myocardium is at risk and you have picked it up early. Next is a hyperacute T wave. So you can get hyperacute, broad-based, bulky, large T waves in certain leads, and as per in which leads they are present, you can localize them for ischemia. Then you have a pattern called as the D Winters T wave, in which you get tall positive T wave with upward sloping 1 to 3 millimeter ST depression. So you get a upsloping ST depression with tall T waves in the precordial leads. Again, a sign of proximal LAD. Then one of these OMIs is actually a multi-vessel pattern, a slanger pattern. So a slanger pattern means there is an ST elevation in lead 3. There is an ST depression in the V4 to V6 and ST elevation in V1 is higher than V2. This actually suggests there is an LCX or RC occlusion in a multi-vessel occlusion. Then there is something which is a very favorite question of multiple quiz examiners. That is the South African flag sign. In the South African flag sign, you can see here in the arrangement of the 12 lead ECG, you get ST elevations in lead 1, AVL and V2. Whereas in lead 3, you get a ST depression. This is called the South African flag sign because it resembles the South African flag and it is seen in the occlusion of the first diagonal of the LED. As you know, 1 and AVL, they are lateral leads. 1 and AVL, they are lateral leads. So occlusion of the first diagonal of the LED will lead to the South African flag sign. Next is a new onset bifascicular block. So here you can imagine we have already studied this, that the QRBP pattern localizes you to the proximal LAD. So you do not think too much here. A posterior OMI, as we have already discussed, ST depressions in V1 to V3 or V1 to V4, which are horizontal ST depressions with upright T waves having a broad R more than S in V2 is more than 1. These again localize to LCX or RCA depending on how the posterior wall is being supplied. One of this changes here is a terminal QRS distortion. It is due to LED occlusion, not very important. Sarbosa-Smith, it is useful when there is a left bundle branch block or if there is a pacemaker in C2. Sarbosa-Smith, the modified criteria, where the first criteria says any leads having concordant ST elevations. um, the second criteria talks about V1 to V3 ST depressions, and the third criteria talks about discordant ST elevations uh, having an STT ratio of more than 25%. In these cases, wherever these criteria are fitting, you can localize the ischemia as per the ECG. Then there is a precordial swirl pattern, again telling you about LED occlusions where there is a V1, V2, ST elevation and an ST depression in V5, V6. This is called as the precordial swirl when there is a northern OMI. Why is it called so? Because if you look at it in a 12 lead ECG, this is the AVR, this is the AVL, AVR and AVL. So in the frontal plane, if you draw it, this is the north, this is the south, this is the east, this is the west. So if you get changes in both AVR and AVL, it is a northern occlusive MI. So any ST elevation in AVR and AVL with negative T waves. So ST elevations are present in AVR and AVL with negative T waves. Along with that, 2, 3 AVF, V4, V6 have ST depressions in the inferior leads or a positive or biphasic T wave. In this case, this is called as a northern OMI. And where does it localize? Usually you will have an occlusion at the bifurcation points of the left anterior descending and the T1. That is somewhere in the mid or distal LAD. That is where you will have the occlusion. Okay. So this is the northern OMI pattern. So these are all patterns of occlusive MI. So as you can see, none of these fit the typical criteria of the ST elevation MI. And many of these give you an idea. It's the proximal LAD which is involved. So the Wellen syndrome tells you it's a proximal LAD. The D-winter T waves tells you it's a proximal LAD. Then your northern OMI tells you to LAD and D1. Your precordial swirl takes you to LAD occlusion. Your terminal QRS occlusion takes you to LAD occlusion. And a new onset bifascicular block also localizes to a proximal LAD. So the funda that I will give you here is that if you see a non-ST elevation occlusive MI, first of all, congratulations, you have picked up a difficult pattern. Second, more likely than not, even if you are able to forget all of this, you can think that it is likely the proximal LAD that is involved. That means a large area of the myocardium is at risk, and immediately you should take up the patient to cath lab. You should alert cardiology, and the patient should be taken up. Now, certain small things. So this was all about the approach to localization to arteries. Some small points that we shall be covering. One is related to atrial infarction. So whenever there is, so in atrial infarction, what actually happens is there are two segments that are involved. This is the previous T wave, then you get a P wave, then you get a RS, whatever. Okay, so you get a PR and this is your T. So there is a TP segment and there is a PR segment. So what actually happens is there is TP segment elevation in atrial infarction. But what we usually are able to see is, so what happens to the baseline is this goes up and the PR remains normal. This is the PR, this is the TP. So what we usually comment is the PR depression. So atrial infarction is picked up using PR depression. So atrial MI, the finding is PR segment depression. Okay. That is the classical finding. So as you can see here, this is the T, this here is the next P. So you can make out the PR depression. You can make out the PR depression in this area. So PR segment elevation or depression indicates atrial infarction and the baseline is the TP segment. So leads 2, 3 AVF, you will be able to see in this case, look at leads 2, 3, you are able to make out in AVF, you are able to make out these changes, and there's a elevation in case of AVR in this case. So how do you localize in these cases? So for that you should be able to know that there is a right atrium and there is a left atrium. So the left atrium actually faces posteriorly. It faces the esophagus. That is why it is better visualized in a trans-esophageal echocardiogram. So the posterobasal left atrium and the more anterior or the anterolateral right atrium. So this is the right atrium, this is the left atrium. So the left atrium is visualized by TP segment elevation in lead 2, lead 3 and reciprocal TP segment depression in lead 1. Whereas for right atrial infarction, you look at PT segment elevation in lead 1 and reciprocal depression is seen in 2, 3 and V2 to V4. Okay. Because here this is a anterior change. So TP elevation in the this lead and TP depression in the inferior leads, right? Whereas in the posterobasal case, it's a elevation in the inferior leads, that is the 2, 3, and a depression in lead 1. So think of it as a TP segment elevation. Although classically we describe it as a PR depression, both are the same thing. Okay, that is about atrial infarction. So now going over some arrhythmias in myocardial infarction. First is a complete heart block in a acute myocardial infarction. So if you look at this, then you have to look at some important things here. You can see here that you are able to make out separate P waves. Okay, so the atrial rate here, if you are able to make out here, look at between these two P waves. The atrial heart rate is coming to be around 100, around 80 in this case, 80 to 100. And the ventricular rate here is they're separated by quite a distance. It's around less than 60, so it's coming to be around 40 here. And this is actually a junctional escape rhythm. And there is inferior ST MI you can visualize here, because you're able to see that ST elevations are seen in leads 2, leads 3, and lead AVF. So you can see prominent ST elevations in these leads. ST depressions is seen in precordial leads. So there are reciprocal changes along with ST elevations. So it is an inferior STEMI. And in fact, this is a complete heart block. Whereas early on, you might see a Venki back phenomenon, which is a Mobitz type 2. So both Venki back or complete heart block may be seen in case of acute MI. And it's very important to know whether it is an inferior wall or a anteroseptal wall. Okay. So if it is an inferior wall MI, so let's just discuss it in terms of what is happening with regards to the uh, conduction system. So what is there is, this is your, let's say this is your atriums, these are your ventricles. Somewhere here you have the AV node giving the bundle of His, which is dividing into the right bundle and the left bundle. So you see, it is always going to be either affected in an inferior wall MI, okay, or if it is a anterior MI, then it has to be an anteroseptal involving the septum, because here you have the septum. So the septum has to be involved. So it can either be in an anteroseptal wall MI or it can be in an inferior wall MI. Now, remember I told you that the AV node is supplied by the RCA in 90% of the cases. So in an inferior wall MI, this AV node undergoes ischemia, and because of that you get complete heart block, and that is superior to the bundle of His. So it is a suprahissian infarction. Okay. Whereas if it is an anterior septal wall MI, the AV node is actually intact. The heart block is due to the damage to the septum. The septum itself, the myocardium of the septum is damaged. So this conduction is totally affected. So if you get a occlusion in inferior wall MI with congenital, with complete heart block, it is an RCA. Whereas in an anterior septal wall MI, it is a septal occlusion. So it is proximal to S1. It is proximal to S1, which will usually be in an isolated septal occlusion or a proximal LAD occlusion. And remember here, this was due to the AV node ischemia. And if you do a successful PCI for it, it will resolve. So it is transient, it resolves with reperfusion, and it is relatively benign. Narrow QRS escape rhythm. Whereas if it is seen in anteroseptal wall MI, it indicates that there is extensive necrosis of the septum, because of which the Hessian, infrahessian bundles itself are effective. There is a wide QRS escape rhythm indicating that it is a ventricular escape rhythm. So what you get here is a ventricular escape rhythm, and this often requires pacing. So it is a more dangerous thing. That's why complete heart block in MI is a important topic. Small point on AFib and MI. So here what you can see is P waves are not well made out. ST elevations are seen in the inferior leads, in leads 2, 3 and AVF here. AVF and 3 are very prominent. And this indicates that there is atrial infarction in MI. So again, that is AFib is a sign, and patients with atrial fibrillation, um, any atrial fibrillation, often usually they have triple vessel coronary disease, and initial their flow after reperfusion is also less. So atrial fibrillation in MI is actually a poor marker of how it will respond to PCI. And why does AFib in MI occur? So you can imagine that if your atria are getting infarcted, this is electrically unstable infarcted tissue. So it is a fertile source, a substrate for atrial fibrillation. So new onset AFib can be seen here. The management is same as what you will manage in a routine atrial fibrillation. If the patient is unstable, you have to give DC cardioversion. If the patient is stable, you see the ejection fraction and LV dysfunction. If LV dysfunction is present, it is acute heart failure. Beta blockers are contraindicated, so you have to go with amiodarone. However, if LV function is preserved, you can still go for beta blockers. Looking at the clinical picture of the patient, you can go ahead, give metoprolol, and do rate control for such atrial fibrillation. Other thing to look at is in a stable patient whether CHA2DS2-VASc is positive. Then if CHA2DS2-VASc is present, so remember for MI you are going to be giving dual antiplatelet therapy, and for this CHA2DS2-VASc positivity you are going to anticoagulate it. So this is one scenario where you are going to give anticoagulation and dual antiplatelet therapy. So you are giving two antiplatelets and you are giving one anticoagulation. So this is called as the triple anticoagulation therapy or the triple therapy. So this is one of the indications for triple therapy. And here, if you have flutter instead of atrial fibrillation, that usually tells you that it is the right atrium that is involved. So it usually means inferior wall MI. And yeah, so these things can be seen in these scenarios. Last thing is last arrhythmia to be aware of in MI is accelerated idioventricular rhythm. Accelerated idioventricular rhythm. So idioventricular because it is a ventricular rhythm first of all. So the V part means it is a ventricular rhythm. So the QRS complexes are broad. So the important thing why this is important to know is it usually happens in patients who are post thrombolysis. So post thrombolysis, you are always concerned that okay, it is possible that the occlusion, the plaque might go and the patient might deteriorate and patient might go into VT. So you are looking at the rhythm, you are seeing that broad QRSS complexes have appeared. So now you are worried, has my patient gone into VT? The important thing to look here is that you should look here at the rate. So even though rate might have increased, it will never go beyond more than 120. If it's going around 160, 200, it is a VT. But here you are seeing broad QRSS complexes with a rate of, in this particular ECG, around 80, 90. It's around 90 here. P waves are not visible. So again, your P waves have gone. Broad complexes, rate of 90. So this is actually a benign finding and indicates that there is successful reperfusion. So in this case, you can probably make out here that this was an anterior STEMI which has undergone reperfusion. So rate between 50 to 120, unlike a VT. QRS's complexes are broad. So three or more complexes with duration of more than 120 as is seen in VT, but there is no real tachycardia, at least not beyond more than 120, and you are able to see fusion and capture beats. This is considered to be due to enhanced automaticity of the ventricular pacemaker. The ventricular pacemaker becomes more active, the ventricles discharge at a faster rate due to the reperfusion that they are getting. So it is due to the ectopic ventricular pacemaker, which has a rate faster than the SA node. So for some time during that reperfusion, it takes over the SA node, and the rhythm that you get is a ventricular rhythm. Why this happens is something we don't know. That's why it's called as a accelerated idiopathic ventricular rhythm. So it is idiopathic. The cause we do not know, and it is often due to increased vagal tone and a decreased sympathetic tone in the reperfusion part of your body. Okay, so now that it brings us to an end of our discussion. So we have discussed going from occlusion to ECG, from ECG to occlusion, small part about arrhythmias, small part about atrial infarction. So that brings us to an end. So we can have a small discussion on certain ECGs and what were the relevant coronary findings that we were able to see in this. So just have a look and approach these with me and try to localize, try to pause here and try to see what is the localization. So what you can see here is ST elevations in leads 2, 3 and AVF. Then, so one thing that should be very clear, if you get ST elevations in 2, 3 AVF, think of the fuel algorithm. Go back to the fuel algorithm. If there is ST elevations in 2, 3 AVF and V4R is not available to you, you have to look at lead 1. You have to go to look at lead 1. If lead 1 is having a depression, it is RCA. If lead 1 is having elevation, it is LCX. If that is not very clear, then you have to look at whether ST elevation in 2 is more than 3. If that is the case, it is LCX. Whereas if that is not the case, then you look at ST depressions in V1 to V3 as compared to the ST elevations in 2, 3 AVF. If these depressions are more prominent, it is LCX. Otherwise, it is RCA. So what you can see here broadly is lead 1, it is not looking elevated. So it is not the LCX in that way, but somewhat I will call it isoelectric or depressed. So let's take it as isoelectric. So if it is isoelectric, you have to know ST elevation in 2 more than 3 or 3 more than 2. So it is 3 more than 2 in this case, likely RCA. One more criteria we will check is whether V1, V3 ST depressions are more prominent than the elevations in 2, 3 AVF. So we are able to make out that the depressions are not so prominent. So that means it is not the LCX, it is the RCA. You can go back in the video and look at the fuel algorithm. So definitely the occlusion in this case should be the RCA, and we do not expect any abnormalities in the LED. So this is a RCA localization. So what was done here, look at here the coronary angiogram finding. So this was a diabetic male with a inferior wall MI having RV dysfunction. So it is definitely a right coronary artery occlusion with involvement of the coronary branches here of the right coronary artery. So what was done is a PCI was done for this, okay, to the right coronary artery, and LED LCX were normal. Now in this second ECG, what you can see here is, you can see here one, that the findings are very subtle. Okay, findings are not very pronounced. So you have to be very careful in looking at this ECG. main thing that you are able to pick up is that there are ST elevations in the inferior leads. So 2, 3 AVF are having some ST elevations. 2, 3 and AVF are having some ST elevations. So it is either RC or LCX. Okay. And when you look here, you are able to make out ST depressions here. Prominent ST depressions in V2, V3, V4. So V1 here is isoelectric. V1 here is isoelectric. Whereas if you look here, if you go back here, I my mistake said V1. We have to look at lead 1. We have to look at lead 1. So here itself you can look lead 1 is having an ST depression, which also helps us localize it to the RCA. So if you look here, lead 1 here actually here does not give us too much of a clue. It is isoelectric. And but the good thing is the ST elevation in lead 2 is more than lead 3. So that takes us to the left circumflex artery. Again, the fuel algorithm comes to our rescue. So left circumflex artery here, 2 more than 3 AVF ST elevation, depressions in V2 to V4 that are much more prominent than the ST elevations, and that can sometimes even go up to 5 millimeters. So actually the culprit here was a obtuse marginal occlusion, and a thrombus was present, and PCI was done for this occlusion. Now going to the third culprit, what you see predominantly here is V2, V3, V4 ST elevations. They are striking, they are very striking. They are looking at you in the eye that there are ST elevations present. Then if you look at this, there are ST depressions in 3 and AVF. 3 and AVF are having ST depressions which are more than 2.5 millimeter. So it is proximal to D1. But as you can see here, there is no ST elevation in AVR. There is no ST elevation in V1. So likely it is distal to S1. So that means it will be a mid LED occlusion. And of course, I knew these angiograms from before, so I'm able to do it very fast. It takes some practice. So it is a mid LED occlusion. Mid LED is occluded, and PCI to mid LED has been done. Next is going to this particular ECG. So this is actually not a very classical pattern, first of all. This here is a staged, so I will give you some clinical picture here. So for this patient, PCI to proximal LAD has already been done. Now he has come to us. So what are the findings that you can note on this ECG? One important finding that to see here is there is an ST elevation in AVR. There is an ST elevation in AVR, but there is not so much of an ST elevation in V1. V2, V3, V4, V5, you are able to make out some upsloping ST depressions, upsloping prominent ST depressions with upright T waves. And if you remember, we call this the D Winters T wave. So both of these things are localizing to the proximal LAD. But we have already done intervention for proximal LAD. So actually what happened is this patient was taken up for a staged PCI. So already PCI to LAD was done. Now he was taken up for LCX because LCX had a proximal LCX occlusion. So he was taken up for a management of a occlusion of the left circumflex artery. So intervention has been done on the left circumflex, but that LAD where the stent has been placed also has a proximal LAD occlusion. So there are definite signs of proximal LAD occlusion on this ECG that we are able to make out. So in this ECG, the takeaway here is that one, what is D Winters T wave, how to pick them up. Second is the concept of staged PCI. We will have a discussion on it towards the end when we talk about guidelines. Okay. Now this one is one ECG you have already seen before. We are able to clearly see the QRBP pattern. So QRBP localizes to proximal LAD, and indeed here what was done was thrombosuction to the proximal left anterior descending. Even the ostial has some occlusion, so this was occluded. So this was touched. So one more point to note in this angiogram that I want to highlight to you is the ramus intermedius. That is, a comment is given regarding it being normal. So that means instead of the obtuse marginal, the anatomy here had a ramus intermedius. Okay, so this patient was a diabetic patient who had an anterior wall MI with a new onset biofascicular block, which is the occlusive MI pattern, and it localizes to proximal LAD. So that is how we do localization on ECG, and that is its clinical relevance. Now coming a bit on the clinical relevance part of things, one question we had discussed, one significance that we had discussed is to decide on who gets to go to the cath lab first. So in the 5 occlusions we have seen, these were the procedures we have done. Take a minute and decide which one will be taken up for the cath lab first. The answer is based on what is the extent of the myocardium that is injured. Likely proximal LAD, it is called the widowmaker artery for a reason. So proximal LAD needs to be taken up first. Then LAD mid needs to be taken up. Then you want to take up the major OM that also supplies a large part. The LCX occlusion can be taken up next. But in fact, this is a staged PCI, so actually I will take it up at the last. And then fourth number will be the RCA occlusion. So this is the order: proximal LED, mid LED, terminal OM. Then because this is a staged one, you can take this up last to the cath lab, and this one can be the fourth one. Now coming finally to the current recommendations. So before I go to the current recommendations, I will just explain to you what happens. So in an MI, it is assumed, especially in ST elevation MI, that there is an acute occlusion of one artery. Okay, it is very unlikely that there are multiple arteries which are developing critical occlusions at the same time. That is the funda behind all this. So in all MIs, it is assumed that there is only one infarct-related artery that is called as the IRA, or the infarct-related artery, which we have localized during using the ECG. But the anatomy, not the acuity on the angiogram, might show you some occlusion here, might show you some occlusion here. So these are actually likely unstable plaques. So the paradigm was that in PCI, you should only stent this, because there is increased inflammatory milieu. If you go ahead and stent this or this, you might cause dislodgement of these unstable plaques and lead to additional damage to the myocardium, and there will be no benefit for this. Another possibility was sometimes these may be providing collaterals to this. So if instead of stenting this first, you go ahead and touch this, what can happen is these collaterals might get damaged, and this part of the myocardium which was already undergoing an MI, you have caused further damage to it. So what the guidelines say on this currently is the current recommendations for the American Society and the European Society I am going to present to you. Just have a look at what they say, and we will discuss briefly as to what is going on. So what the American guidelines tell is that routine complete revascularization. So basically what we talked about here, so only stenting this infarct-related artery is called as an IRA only approach. Whereas doing intervention on all arteries which have critical stenosis is called as a complete revascularization approach. So American guidelines say that do not do complete revascularization, and that is a class 3 recommendation, which means that if you do complete revascularization, you are causing harm to the patient. So first principle of medicine is do no harm. So class 3 recommendations are taken very seriously. So you should not do complete revascularization, and if you are doing non-infarct-related artery PCI, you should defer it after successful primary PCI of the IRA. They give a class 1 recommendation that you can do staged PCI during either the index hospitalization or within 45 days of the primary PCI. The European guidelines, which are actually old, they come in the year 2017, and there are some trials which have come within these 4 years between the European and American guidelines. They say that if a patient has a cardiogenic shock, then there is a conditional recommendation, that is a class 2 recommendation. That means there is no harm, benefit uncertain, but you can do. They tell that in patients who have cardiogenic shock, infarct-related infarct-related artery PCI, you go ahead and do. In such patients, you should also do non-infarct-related PCI. They say that it might help in the cardiogenic shock component. You might recover more part of the myocardium. And before hospital discharge, again, there's a two-way recommendation for staged PCI. Here, the recommendation is to do a staged PCI before hospital discharge. But we go ahead with the current American recommendations, which say that do not do complete revascularization, and you can defer the non-IRA PCI after PCI of the IRA. So these are the list of the trials. This is more at a DM cardiology level than at the postgraduate level. So these are the list of the trials that you had: the PRAMI trial, the culprit trial, the Primulti trial, compare acute, complete, culprit shock, and flower MI. So all of these have looked into different timings of revascularization. Some of them have taken revascularization during the index admission. Some of them have specified a time point of the less than 45 days. So first infarct-related artery PCI was done. Here discharge was done, and here elective PCI has been done. So elective PCI can either be guided by angiography or by fractional flow reserve. So some of them have looked at, like the complete trial has looked at both fractional flow reserve and angiographic guided, whereas some trials have only looked at one method of deciding the strategy for complete revascularization. So this is a table which is more relevant at the DM cardiology level, and the postgraduates and the interns need not focus on this. The current recommendation is regarding STEMI with multivessel disease. After the successful infarct-related artery PCI, If it is unstable, your recommendations are not very certain, because your European guidelines in this case tell you that you should do non-IRA PCI. That is a 2A recommendation. This guideline is yet to be updated, and the American guidelines are silent on it. In a stable non-IRA lesion, as your American guidelines say, that you should do a staged revascularization. If it is suitable for PCI, you can do it either during index hospitalization or do another admission within the next 45 days. And that guidance can either be angiographic or based on fractional flow reserve. If it is not suitable for PCI, multivessel disease can be managed with CABG. So, one important takeaway from here as an intern, as a postgraduate, whenever you see the words multivessel disease, do not jump to thinking that that the management is CABG. You should know what are the indications for CABG and what lesions can be taken up with a percutaneous coronary intervention, because those are less morbid interventions. Some small other things that were brought up during the original presentation that I presented, which were discussed during that presentation. One is shark fin ECG. Here what happens is this V3, so these are often seen in ICU patients, the V3 to V6, they will show giant amplitudes of R wave. This ECG looks very dangerous, and it is merged with the ST segment. It resembles your shark fin. So it is called as the shark fin sign and the lambda wave pattern. And these are also in suggestive of occlusion of the left main coronary artery. Often these patients will not be able to make it. So left main coronary artery, they have a high risk of death, high risk of going into cardiogenic shock and cardiac arrest. So shark fin ECG. Other finding that is very commonly seen in ICU patients, and in fact, it is a benign finding. In critically ill patients, you can see some ST segment elevations, especially in lead 3. So these, what happens is that these patients actually do not have ST elevation MI. It is due to their critical illness that you get ST elevation MI in an artifact. So this apparent ST elevation is actually in the form of a dome and spike pattern. So it resembles the helmet that was used by Russians in the by the Prussians. So the German military used the spiked military helmet. So it resembles that spiked military helmet, and that's why it's called as the spiked helmet sign. It indicates there is no occlusion of the artery. You should not take the patient for PCI. In fact, it is due to the critical illness, and there is definitely high risk of in-hospital death, but it is an STEMI artifact. Some other questions that were asked during this presentation is, which is more dangerous, the right bundle branch block or the left bundle branch? Other thing is, we have a Sarbosa Smith for the left bundle branch block, but not for the right bundle branch block. What is the reason, and why does it not mask the changes of MI? Other questions, why does the Slanger pattern happen? Do more number of ST elevations indicate more damage? This is one question we have already have answered, and we have also discussed the AVR ST elevation anxiety conundrum. So these were some questions that were asked to me by my consultants during my original presentation. And with that, we come to an end of this presentation. It was slightly longer than I had originally intended. The reason is I went a bit slow. So I would like to thank you all for listening to this. I hope this was useful for all of you. And the reference book from where I have taken a lot of my content, rest of the relevant references from the Smith's ECG blog and other places I have given at the relevant places. This is the 12-lead ECG in ST elevation myocardial infarction, and its authors are Bayes de Luna is the main author for this book, and other contributors are Fiol, the cardiologists who have given the Fiol algorithm, and Antman. So these are the three authors of this book. It's a beautiful book, gives other images regarding how the injured myocardium will look like on the echo, what segments of the left ventricle will have LV dysfunction, segments 1 to 17, how do we map them. So this was the source for most of the ECGs, most of the injury vector images. And I would like to really thank the authors for coming up with such a book. So thank you so much all for watching. That was about infarct artery localization and its clinical relevance. I'm Dr. Chaitanya, and that was the presentation. Thank you so much.